Good afternoon, everybody. Thanks for coming. So the title of my talk today is The Core Laboratory, Built for Speed. I don't have anything to disclose. So here's the outlines of what I will talk today. So first, I will give you a brief introduction of the core laboratory in Seattle Children's Hospital. Then I will talk about how the implication of the lean improvement get to the improve in the core laboratory. Then I will talk about two most recently improvement in the core laboratory. One is on the respiratory viral testing. The other one is the implement of rapid neutrophil count. So finally, I just gave you very brief the dream of my core laboratory. So first is the history of core lab. Dr. Dennis Benjamin, who was the medical director previously prior to Dr. Joe Rutledge, he actually left children in 2000. So somewhere in the mid-1990, about 20 years ago. So there was a few challenges occur in the laboratory. So first is the financial downtime at that time. So the hospital went through a major re-engineering, and the cost cut strategy at that time is to reduce the staff to increase the efficiency. So actually the core was, at that time it's not core, the laboratory is kind of reduced in size. And at the same time, one of the hematology supervisor retired. And also during that time, the coagulation laboratory only has one specialist. So at that time, the techs are specifically stay in one discipline. They either hematology, chemistry, or coagulation. There was only one coag tech. But I guess at that time, it's still like the fibrometer or the stopwatch. But when that person is on vacation, so they have a hard time to cover the service. So with all this consideration at that time, probably the light bulb lit in Dr. Benjamin's head. He said, why don't we just combine all these specialties and make a core lab so we can get good coverages. So that's how the core lab started during that time. And this core lab is a little different from the other core labs in the large reference laboratory. So this is basically, it's a rapid response lab. So it consists of all the specialties, but they only perform the tests which need a fast turnaround time. So this is the core lab now. So we have one manager, 2 supervisors, 1 day shift, 1 evening and night shift. We have 35 FTEs, not 35 technologists. And we cover the 3 shifts, day, evening, and night shifts. So the advantages of a core laboratory is everybody is trained in every specialties. So we have no trouble finding the coverage for all the benches. But the disadvantage is that we lost the specialty. So basically everybody can do everything. Then nobody is specialized in certain area. So that's why the mini team was built. So the mini team basically consists of several technologists who are interested in specific area. For example, chemistry. So these people will do calibrations, major calibrations, instrument correlations, calibration verification, AMR verification, and also do the troubleshooting and even reagent ordering. So if anybody, the team has any problems, they will go to the mini team members to ask for the help. For the coag, besides doing all this like the chemistry people do, and they also do special tests like factor assays, lupus screens. So those are the function of the mini team. So that works very well for those years. So what we do in the core lab, so we have 3 major large instruments: chemistry, hematology, coagulation. And we also do urine analysis, blood gas, and we do the urine drug screen and the cardiac markers on the bedside instrument. And just 2 years ago, we implemented the respiratory viral PCR test, which I will talk more in detail. And we also perform some manual tests, like a sickle cell screen, monospot, pregnancy test. So all these little tests also performed in the core lab if they need a fast turnaround time. So this is the overall of the core laboratory. So next thing I want to talk about is the lean. So lean, it means is the elimination of waste. So what's the waste? So waste, we define the waste is that which consumes resources but does not add values. But in most cases, actually, the type of waste, when you look at it, it looks like they are the work, like a rework, error correction, waiting time, excess motion, overproduction, and travel or material handling, like excess inventory, excess processing. All of this looks like a work to us, but actually they're kind of a type of waste. So the major thing for the lean is to get rid of the waste. So at the Seattle Children's Hospital, the lean journey started 10 years ago. So it made a significant transformation of the hospital. So they used the principle called the continuous process improvement, the CPI principle. So the first thing of this is to eliminate the waste, then eliminate the variation to define the standard work. Finally, is continuous improvement is the most important. So how they do the continuous improvement, they use the metrics to look for the result, then to see what needs to be improved continuously. So people usually say the lab is not a car factory, using the Toyota strategy that fit to the laboratory. But if you look at the laboratory, what part of laboratory is more like a factory? It's the core lab. So in the core lab, we offer 24/7 operation, and we perform 60% of the test volume in the whole laboratory in Seattle Children's Hospital, although we only have 1/3 of a FTE. So what we did in the laboratory, we did our first major project 8 years ago, and this lean project started in the core lab. So we have one consultant embedded in the lab for a couple months. Then we have our internal people to form a team. This team consists of 2 technologists, 2 lab assistants, and a core lab operation manager, as well as a representative from the hospital. So this is our lean team members at that time. And these people actually, they work full-time for first 3 months, then later on extended to 5-6 months, full-time work on the lean. So the tools they use is first is the 5S. So the 5S represent the sort, simplify, sweep and shine, standardize, and sustain. So for the sort, basically you just sort the things which is negative, what are needed and what are not needed. Just get rid of all the things that you really don't need it. And the simplify is to put the things into the place where it's supposed to be. You don't have to look for stuff all the time. And keep it clean and orderly is the same thing. Then the standards work is very important. So you make all this workstation and equipment in where they're supposed to be, and make the work standardized to decrease the variation. So finally, sustain is the most important, and it's a very difficult one. So usually, you can have everything put in order, then a couple of days later, everything become mess. I remember I was learning what they call the entropy at that time, not entropy, entropy. So entropy is kind of randomness. So the human nature just want to get random. So that's the difficult part. The other thing is visual control. So in our laboratory right now, actually, when you walk in the core lab, you can see everything. So there's no abstraction. And the stuff on the table, I will show you some picture later. So you can see everything where it's supposed to be. And the inventory control, I will talk about this later for how we use the Kanban card to organize the order of the inventory. A3 is a method to tackle the small problems. So we usually have, somebody raise the question of one area which is not optimal for the operation. So we just have a few people get together and list all the problem it has and propose any problem-solving strategies. So this is the small steps to improve the process. Finally, is the metrics. So we still have the metrics every day. I will show you later to measure some key element so we can tell whether the operation works fine. So after organize this team, the 6 people team, they work full time. So they communicate it to the staff every day on a daily basis. So then they do the analysis of the specimen flow. So they look at the specimen, when it's getting to our laboratory, went to the CPA, went to the test bench, then finally the result, they actually walk with the specimen to see how the specimen flow went. Then they make this spaghetti diagram to see how the flow of the specimen. Then they analyze the people. to see how the tech works and how the CPA people work. So they follow their route to make a spaghetti diagram too. So then with all this data, they design the lean workflow. So with this workflow, they find the optimal workflow to design the physical layout of each workstation. Then they develop the standard work process, finally using all the tools I mentioned earlier to make the process move more smoothly. So after this couple months, what they have achieved is they developed a work cell with major reset of the physical layout of the instrument. I will show you a picture later. Then they established a single piece flow standard work and used the 5S to increase the efficiency and established the Kanban system. And finally eliminated some special handlings, disruptions, and non-standard work. So here I show you the spaghetti diagram of the core laboratory. So this is the previously before Lean. And each station has one tech. And this is the coag station. And this is the red is a chemistry station. And the purple is CBC, the hematology station. So we have 3 techs walk around this area. And within a 15 minutes time, they walk 811 feet. So after the rework, after redesign the core, you can see on the bottom panel, they form a kind of a work cell. So on the top, there are 2 instruments, the vitros, the chemistry instrument. On the bottom, there are 2 instruments. So here's the 2 coag instrument, and here's the 2 hematology instrument. So when we designed, only one person, one tech, walk around this area to handling all 3 instruments. So that was at the very beginning, but now during this time the volume increased, so we have 2 techs working the cell. And you can see here, within the 15 minutes time, one tech walked for 242 feet. So it's significantly decreased, more than 50% of decrease in terms of walk time for the walk distance of the tech. So this is the real picture. You can see 2 vitros instruments over here. Then on this side, there's 2 coag instruments. And further down there, there's 2 hematology instruments. So this forms the work cell. And the other thing is the 5S. So after 5S, we organized all the stuff used for the testing. You can see this tape. We taped all the area. Here, and we tape this area. So that's where something's supposed to be there. And there's a label here. For example, here's the rack. So you can use the rack somewhere else, but after you use it, you're supposed to put it back where the rack's supposed to be. So from here, you can actually see everything, but just when you look face to this bench, you will see everything what you need to use. And this is the Kanban inventory system. You can see here, we put a car somewhere inside, like here, behind these tubes, and this. So when you use all the tubes in front of the Kanban car, you saw this car, it's time for reorder stuff. So this is how we organize the ordering system. Okay, so what's all this improvement make our improvement in the testing? So we first look at the stat test. So before, we promised the stat test the turnaround time is 1 hour. Routine test is 3 hours. And actually, we have 60% of sample, they all stat test. So when you have so many stat tests, the lab assistant has to prioritize. The code probably is the most important one you put in the front. Then OR, NICU, PICU, ED, HEMONC, everyone else. So for all the stat tests, then the CPA people has to prioritize. So that actually wastes a lot of time. So after the Lean, so we use the single piece flow. So everything, when the specimen comes in, we just do it. So first in, first out. So no prioritize. Then the routine tests actually take less than hours. So then we just completely eliminated the stat test. We don't have any stat test. Anything comes just single piece flow, first comes, first in. And after this, during the next few years after that, actually our volume increased significantly. The test volume grew about 30%. But during this time, we didn't add any instrument, didn't add any technologist. So this is what the Lean saved us. Okay, so last one, the Lean tool is the metrics. So when we first started, we do this every day. So every day we print out this sheet, and all the administrative work and all the directors huddle in the morning and just look at this sheet. At that time, we don't call it huddle. We just call it meetings, brief meetings. And what we have here, we pick up some representative tests from each instrument. Like a creatinine is a representative test of the hematology instrument. And the CBC diff are the representative tests for the hematology instrument as well as the, the manual diff part. Then PT is the proton, is representative of COAT test. And the UA is the urine analysis. And finally, the iron calcium is a representative test for our blood gas instrument. So we look at, for example, this creatinine. The minimum turnaround time is 12 minutes, and the maximum 33 minutes, with median 21 and average 23. And we can see here 99% of time it's completed within 60 minutes, and 100% time completed within 80 minutes. So if you compare this to the baseline before the lean at 2004, and the 71% can complete it within 1 hour. For the ionized calcium, we actually use a different time limit since it needs to have the faster turnaround time. So we use 30 minutes and 40 minutes as a cutoff. So 100% of that day, the ionized calcium was completed within 30 minutes. So with the times goes on, we actually add more items into our metrics. So the two we added here is HCG and ESR. So around 2000, so about 3 years ago, and Children's Hospital decided every girls older than 12 years old will have a HCG test before any surgical or radiological procedures. So in that case, our volumes increased. And also they need a fast turnaround time. So the patient comes in the morning, get the HCG test, then continue to the procedure. So we use 20 minutes as our cutoff time. So we set this as one of the into the metrics to follow up. And the ESR, the problems with ESR is, originally we saw when the CRP came, we can get rid of ESR, but not really. This is a relic always want to get rid of it, but it hasn't happened yet. So now seems, for the rheumatologist, for the SLE, they actually use both ESR and the CRP to differentiate if the SLE patient is in the flare or is in the infection. So in the infection, the ESR and the CRP, they both increased. But for the SLE patient with flare, the ESR increased, but CRP does not increase. So I don't know how useful it is, but we really don't see the decrease of the ESR. And the problem with the ESR is ESR usually the same tube as the CBC. So we do the CBC, then we transfer to another station. And sometimes it's just lost in the middle. So it's, the delay happens very commonly. So we put this also as a item in our metrics. So this one just show you one of the example, creatinine, turnaround time during the time since we started the lean. So pre-lean, you can see at the very beginning, the median turnaround time, average turnaround time is 52 minutes. And the variation is huge, range from 40 to 70 minutes. So you can see it gradually decreased both the average and also the variation. In 2009, here shows the average turnaround time is 22 minutes, and the variation is between 18 to 28 minutes. So the variation significantly decreased, and the average turnaround time improved significantly. So this is the current metrics we use. So now we don't use the Excel spreadsheet anymore. So before, we have Excel spreadsheet, one sheet a day. And now we have this system called a Tableau. So actually everything in Tableau, you can just click on the date. Everything you can see every day. So now you can see we actually add a lot of them. And beta hydroxybutyrate on the top is the one we want to monitor and to make it quickly. So this is for the patient in DKA, diabetes ketoacidosis. So the endocrinologists really want this to be very fast. So we listed it into the metrics too. So the last two we added here is one is a rapid respiratory viral and the pertussis assay. And the other one is a rapid neutrophil count. So I will talk about this in details later. And then you can see here, for the rapid respiratory virus plus pertussis, We use 120 minutes as a cutoff since the test takes more than 1 hour to perform. So in this case, we did the 12 tests on that day, and 100% of them meet 2-hour turnaround time. For the rapid neutrophil count, in that day we only have one test. It's 4 minutes. So this one we set up as a 15 minutes as a cutoff. I will talk about that in details. Okay, so now I'm going to talk about the 2 major improvements during the past 2 years. So the first one is a multiplex PCR-based respiratory viral assay in core lab. Fumarate. So Fumarate Respiratory Panel is a very integrated, highly automated assay for detection of DNA or RNA containing infectious agent. It's a PCR-based molecular test, but it only takes 5 minutes hands-on time. The results comes in about an hour. And it's technically not very demanding, but we need a fast turnaround time. So that's the reason it was implemented in the core lab. So here shows on the right side is this Fumarate instrument. It's very small, and it's about the size of a shoebox. So before that, you can see on the left side, if you do the molecular test for the infectious agent, you need 3 instruments. So the first one is the nucleic extractor. So it extracts the nucleic acid, either RNA or DNA, from the infectious agent. So after you isolate the nucleic acid, it will be put into the second instrument, which is a PCR instrument. So over there, the nucleic acid is amplified to increase the sensitivity. So then the amplified product will be put into the Luminex to detect the specific targets. So all this now be combined in a small instrument. And the previous study has been performed during the past couple of years. They found that it's very, this instrument actually, some published paper here, shows a very good correlation with other PCR-based method, except adenovirus, the sensitivity is a little lower. So we also found that out in the CAP survey. So we didn't detect the adenovirus of one of the first CAP survey we got. But all the Fumarate labs did not detect it. But now they actually make another software or something, the upgrade. They claimed it's better for the adenovirus, but I haven't seen the result yet. So inside this pouch or inside this cartridge, it combined all the steps in the, first the red one, which is the lysis of the bacteria or viruses. Then they used the magnetic beads to purify the nucleic acid, either RNA or DNA. When you get the nucleic acid, it will go through the 2 stages of PCR. So the first stage is PCR is a multiplex. So they have multiple primer sets combined in the same reaction mixture. So after this amplification, the samples will be diluted and put into the single wells. Then for the second stage of PCR, each well contains only a single pair of specific primers. So then each primer set will amplify the product to increase the sensitivity. So the second stage PCR is a real-time PCR. So the melting curve will be analyzed automatically and give the result as a positive or negative. So although the process is very complicated, the procedure is pretty simple. So on the left side, it shows you use the syringe to withdraw the specimen, a respiratory specimen, and just inject it into the pouch. Then you load the pouch into the instrument. After entering this, the sample ID and operator ID, you just push the run button. And 65 minutes later, the result is printed out. Here, I just show you a report of this respiratory sample containing the coronavirus OC43. And the rest of them are all negative. So it's not very uncommon to see multiple infectious agents present in one sample. The most we saw probably is 4. So this is all the passengers included in this respiratory panel. It consists of 17 different viral agents, and also pertussis, chlamydia, and mycoplasma. Right now, we're doing the 17 virus plus pertussis. We haven't set the chlamydia and the mycoplasma on our panel yet. Although the turnaround time is very fast, only a little over 1 hour, but the drawback of this instrument is the low throughput. So you can only run specimen at one time. So during the winter time, the flu season, we have 50, sometimes 70 specimens a day. So it will take, at most you can run 22 a day. If you run one after another one, you can only run 22. It will take at least 3 days to complete all the specimens. Then, it just be the purpose to get the faster turnaround time. So we purchased the 3 instruments to run day and night to, basically cover the flu season. And also, it's very close to the pneumatic tube system. So whenever the specimen got here, we just load it and let it run. Even with that, we still have backlog during the flu season. Because sometimes the specimen, like 10 specimens, came at the same time. So we can only do 3 at a time. So it takes about 3-4 hours, sometimes 5-6 hours to complete all the testing. So before we have this multiplex DNA testing, we send our respiratory test to a reference laboratory. And at the reference laboratory, the test was performed using the direct fluorescence assay, DFA. So DFA test, it used to be a gold standard. It's technically demanding. It needs a specialized tech to do it. Usually it's the microbiologist tech. And it usually is batch test. It's not a single piece flow. It takes too long to do that. And it takes a few hours of tech time. And finally, it detects only 8 viral agents instead of 20 in this PCR system. So the steps we had before, it's very long. So first the specimen came to our lab, and we accessioned it into the laboratory. Then we transfer this to the send-out groups. The send-out people will package the specimen and wait for the courier to take it and transport it to an on-site reference lab. So at the reference lab, it will be reaccessioned again, and they will perform the DFA test and finally manually enter the result. So it's a long process. So with the implementation of this respiratory panel, we reduced the steps from 7 to 3. Although the value added step only 1, so we only need the test result. That's the only thing we need. So the turnaround time was significantly improved. Used to be between 6 to 24 hours, depending on when the specimen was submitted and when the specimen was transported to the reference lab. And right now, we only have 1 to 2 hours turnaround time. So the number of handoffs and the number of queues are all significantly reduced using the lean term. The only thing increased is the infectious agent we detect. Now we detect 20 instead of 8. We also compare a turnaround time after we start this. So we put this online in December 14, 2011. So for the first 4 months, we performed 2,537 respiratory tests. And the mean turnaround time is 1.6 hours, and the median turnaround time is 1.4 hours. So 82% of sample were completed within 2 hours, and 95% of sample were completed within 3 hours. We look at the exactly same period of time the year before. We sent 1,399 samples to the reference lab for DFA testing. The mean turnaround time is 7 hours, and the median turnaround time is 6.5 hours. So 2% of them were completed within 3 hours, and nothing could possibly be completed within 2 hours. So we have, after implementing this test, we significantly reduce the turnaround time. So next thing we try to see is whether this improvement really has any impact on the patient care. So for the respiratory virus, the only one has a specific treatment is the influenza. So the antiviral drug, Tamiflu, is usually used if the patient is positive for the influenza virus. But the guideline for this is the medication should be given within 48 hours after onset of symptom to be effective. So usually, the parent may not seek medical attention when the kids started to have flu symptoms. It may take a day or even 2 before they really go to the hospital. And if the test takes another day, then you basically miss the window period of this 48 hours. So usually the physician may empirically treat the patient if they think by their judgment it's clinical indicated. So what we did is we look at retrospectively review the chart for 1 month of the patient in the ED. And then we found that 97 patients were positive for influenza during the months of March to 2012. And for this patient, we found that 23% of them actually were given the medication while they're still in ED. And 31% of patients was given the prescription in the ED. So basically 54% of them received their test result before they were discharged. So then on the left side, it's 28% of patients were given prescription 3 hours after they were discharged from ED. So for those patients, sometimes some of them, their ED stay were very short. So before our test results were reported to the physician. And some of them, the tests were not ordered soon enough. So the doctor did not order it when the patient entered the emergency department. They ordered right before the patient was discharged. But as soon as the result came out, the doctor or nurse notified the patient, gave them the prescription. So overall, 82% of these patients were treated with or given a prescription for influenza infection very promptly. Only 18% of them did not get any prescription. And some of them, by doctor's judgment, the patient already missed the window period of 48 hours. So giving the medication is really not useful. And some of them, actually, the patient were transferred from the ED to the inpatient. So at the ED, there is no record of the patient was treated or was given the prescription. Only 2 cases of those 97 patients, there's no record of anything. So in summary, there's no improvement in the treatment of influenza virus. So after we implement this test, there are 2 extra bonus we didn't even think about at the very beginning. So one is the saving ED room time. The other one is the confirmation of the clinical diagnosis. So this is the patient flow and the bed placement in the ED. So previously, we sent a specimen for the DFA testing. So the optimal sample requirement for DFA is nasal wash. For nasal wash, you inject the saline into the nasal cavity, then aspirate it out to do the testing. So during this process, you create aerosol. So the person who performed the procedure need to wear gloves and a mask and a face shield. Then after each procedure, the room has to be closed for 30 minutes before the next patient can enter the room. So after we used this PCR test, the optimal specimen requirement is nasal swab. So it's very easy to do a nasal swab. So no aerosols will be produced. And the person who performed the procedure only need to wear gloves, so no shield, no mask. And the room can be used immediately after each procedure, so there's no ED room downtime. And the second advantage is the diagnosis of the virus. So you can see from this chart. This chart is from the flu season 2012 to just a few days ago, actually, in May. And it covered everything. You can see 32% of patient samples were negative, and 68% were positive for a variety of viruses. Although only 8% were positive for flu, so those were the patients who will be treated by Tamiflu. The rest of them, usually, the patient was not treated. Not all, but most of the time, the patient was not treated, especially for the rhinovirus or the coronavirus. However, it's still useful because the doctors know what happened to the patient. So they basically have the diagnosis. And one of the ED physicians told me, now we feels like we were smarter because we tell the parents what the patient have. So the patient will not be put on antibiotics. They do not need any further treatment, further testing, and the parents are really reassured. So this is the summary for the respiratory viral testing. So in summary, we replaced the DFA in a special laboratory with a molecular multiplex PCR in the core laboratory. So by doing this, we significantly improved the turnaround time for respiratory viral testing. And for the patient with influenza virus were treated more quickly. In addition, we improved the ED room availability. That saves a lot of money, although it's not easy to quantify how much money you can save by saving the ED room. And the parents are happy about it because they get reassured of what the kids have. And the physician really get their diagnosis. They feel comfortable too. So finally, the most important thing, we got our first molecular test in the core rapid response laboratory. So since we have a very good response for the first year, and the second year we set up another one in the Bellevue lab. because the physician in the Bellevue lab all think, they should have the same thing as the main hospital. Okay, now I will be talking about the other improvement during the past 2 years also. It's about 2 years now. So it's a modified CBC differential for pediatric patients with the fever and the neutropenia. So the neutropenia patient in the pediatric population usually consists of oncology patients. So those are the oncology patients who are on chemotherapy. And the other population is the congenital neutropenia patient. And this population patient has high mortality rate, especially for those patients with fever. So most time they have a bacterial infection, and the mortality rate is very high. And also it progresses very quickly. So the Clinical Practice Guideline of Infectious Disease Society of America, they put a standard for the pediatric patient. The patient should be given antibiotics within 1 hour of presentation to ED or to the hem-onc clinic. So the challenge for the ED is, they have to communicate with hem-onc fellows to know what patient coming. So for those neutropenia patients, they usually alert a hem-onc fellow first before coming to the ED. So then they give the prescription of antibiotics. So all this process have to be very smoothly to get the patient administered antibiotic in time. And for the laboratory, and the other thing is they need to get a absolute neutrophil count before they give the antibiotics. Sometimes they probably don't, but right now we can offer them. So before we implement this test, for our laboratory, when they submit the blood, we need to do a CBC differential to give them the absolute neutrophil count. So we first run an instrument, then we make a smear. We actually make smear for every blood testing. The reason we did that is just sometimes, if we don't do the smear a couple days later, then the hematologist want to come to see if they see any samples with spherocytes, then we don't have a smear anymore. So we just do it for all of them. And then, if the printout, the instrument, the automated instrument printout has some flags, then we need to scan the slides, and some of them we need to do the manual differential. And for those patients, hem-onc patients, they usually have flags. They're not normal. So most of the time, we need to do a manual differential. So turnaround time will be 1 hour. So in this case, there's no way they can give the antibiotic. They have no way to give the antibiotic within 1 hour after patient presentation. For us, we already take their 1 hour. So with the discussion with the hem-onc doctors and with the ED doctors, we came up with this test we call the rapid neutrophil count. And the name is a little odd, but we think this is the best way to differentiate it from the CBC diff. So what we do is we just use the CBC differential on the instrument. We don't do any manual process, but we don't report everything. We just report the limited parameters like hematocrit, platelet, WBC, and absolute neutrophil count. And if sometimes instrument doesn't give platelet because of platelet clumping, or giant platelet, they just have the star there. So you have to really do the platelet estimate. And sometimes the WBC or the differential, the instrument just don't give it to you. So in those cases, we have to renew the smear. So the turnaround time will be a little slower. But those are the rare cases, not very common. And also this patient population are known to the hem-onc doctor. They're not the patient that just randomly walking on the street. So they have some kind of expectation to see all the parameters. So in case there's some really random errors, they probably will pick up and will repeat the CBC diff. So before we implement this, we did some kind of a very rough evaluation. So we just random pick up any printout during that day and find a couple of samples with manual differential. So during that day, we get 47 manual differentials. Then we plot it with the automatic result. It correlated very well. Then we also look at the WBC less than 500. And it's a little, not as good as the higher WBC, but it's also pretty good. And we also look at platelet. So there are a few samples, the platelet was either too low or there's some there's some flags. So we did a manual platelet estimate. So correlate very well between the manual estimate and also the the automated instrument. So we decided to offer this test just called a rapid neutrophil count. And it's only ordered by hem-onc doctor and the ED doctors, so in their order sets. So you can see here from the start to now, we only did 390 tests of this rapid neutrophil count. The mean turnaround time is 11 minutes, median 7 minutes. So 89% of the samples were reported less than 20 minutes, and the 94% were reported less than 30 minutes. So if I collected all the CBC diff, the mean turnaround time is 26, median is 22. And only 24% of time we hit the 20 minutes mark, and 38% hit the 30 minutes mark. So that really makes the difference. You know, if we can do everything within 30 minutes, they still have the chance to give the patient antibiotics within an hour. So this is actually the result from the ED and the hem-onc. So the different color, the blue color is the first quarter. That was the end of 2001, the last 3 months of 2001. The second quarter is actually the first 3 months of the 2002. Then the third one, the third quarter is from April to June of 2012. So we implemented this test in the middle of the red part. So we implemented in February of 2012. So you can see on the left, very left, is the clinic, is the hem-onc clinic here. So this is the 3 quarter. This is actually the time from the order of the antibiotics to the administration of the antibiotics. And the second part is the ED. It's also for the time for the antibiotics order to the antibiotics administered. So you can see the time, it's about the same, didn't change that much. But if you look at this, so this, and this is for clinic, the right part is for the ED. So this is a time when the patient entered the hospital, entered the ED or to the hem-onc clinic until the time antibiotic is given. It decreases significantly. If you look at the last quarter, the green bar, actually they hit the time less than 57 seconds. So they make their standard for giving the antibiotics 1 hour after patient presentation. So they're very happy about this test. But for us, sometimes there's some confusions. We told them if you order this test, you cannot order CBC diff. We're not going to do both on the same specimen, because otherwise we have to correct the result. We have to credit the patient. So some of them, they do this. Then afterwards, the next day or something, they will do another CBC diff. Okay, in summary. So first part is about lean. So we improved the TAT of all our lab tests in the core laboratory using the lean strategy. And we completely eliminate the stat test. And the second is a multiplex respiratory panel. So we implement a molecular PCR respiratory viral testing in the core laboratory, which significantly improved the TAT of the respiratory viral testing, and also make the treatment for the influenza infection faster. And finally, the rapid neutrophil count implementation decreased the time for fever and the neutropenia patient receiving the antibiotics. So what about the future molecular test in core lab? So if an infectious disease test needs to be done rapidly, and we can do it on this test. So right now, during the flu season, we really have a lot of samples to be run for the 3 instruments. But during the summer, actually the one you saw earlier, right now we only have like 10 tests a day. So only need 1 instrument. The other 2 instruments just idle there. So we feel it's so wasteful. But if the summer we have some other panel like meningitis panel, diarrhea panel, that would be very cost effective for using the same instrument. And also for the core lab techs, they're really capable of doing a lot of things. Although we did extensive training at the very beginning to educate everybody about what's the nucleic acid and what's the PCR, and they're really excited at learning that, and they really enjoy the process. And at the time when we set up this test in the core lab, actually, the microbiology lab does not have the 24/7. They were the one that did the initial evaluation. But we set a core lab just because, the most important, I should say the major reason is the 24/7 service. But right now, microbiology already established their 24/7 service. So we're talking about some other tests that we should transfer back to to the microbiology lab. So when I ask people about what about Fumarate, they say no, we want it. So they really think it's something new for the core and something exciting, and they saw the impact on the ED patient, so they really like it. And well, actually, molecular biology is dear to my heart. So my PhD, my postdoc, all work on the molecular biology. So after I before finishing the resident, I was thinking about going to the molecular diagnosis, but it didn't work out. So originally, I was planning to. At that time, the molecular pathology specialty did not exist at that time. So I was just thinking about doing the cytogenetics, molecular genetics. So I applied at NIH since I want to stay at DC area at that time due to family reasons. But they didn't take me. So the fellowship there is combined. There's 3 years fellowship. They combine the medical genetics, cytogenetics, and the molecular genetics. So the first question they asked me when I went to interview, say, are you ready to see the live patient? So all their fellows, basically, they're physicians. They're either internal medicine or pediatricians. Only one of them, they accept a pathologist. Since I was from medical school many years ago, so they thought I won't be able to see a live patient. I can only treat dead bodies. So that's the end of my molecular career. Sorry, I didn't mean I don't like my current job. I really enjoy my job. Sorry, we have a talented and a very cooperative group in my lab. So what's the future lab? So actually this one is a University of Washington lab in 1900. I got this randomly on the on the website. I just this I can put into the grant round, and actually this is preserved in the laboratory, and it's called the Icy Lab. There was another picture they called the Icy Shop. So this is the this is 20th century, right? So 50 years later, you can see, we're still doing this manual stuff with, even mouse pipetting showing here. Then 2000, we have really the complete automation in the lab. So what about 50 years later? Anything could happen, right? So mass spec, next-gen sequencing, they could all enter the core lab. This is just I know it's not in the foreseeable near future, but it's not impossible. So now I don't have to go anywhere. I'm just waiting in the core lab, waiting for them to come. And never say never. This is what my mentor, Dr. Robert Dufour, he also told us, never say never. And he told a story how he became a clinical chemist. So finally, I want to acknowledge the following people. So Dr. Joe Rutledge was behind everything. Start from Lin, from the Fumarate, and also the rapid neutrophil count. And Dr. Michael Ashton was the major force behind the Fumarate and also the major force for the publication of the AJCP paper. And Joanne Simpson is our is our administrative director, also behind the Lin and also the Fumarate. And when we have this Fumarate set up, it took a lot of people. And Joanne was saying, I have never had so many emails regarding to the single subject. So we were having so many people doing back and forth the email. And the core laboratory, of course, they're doing everything I've been talking about. And Suchinda is our CIS person, and for all the projects, she also involved. And Dr. Shun Chin, who is our microbiology director, and she was the one who brought the Fumarate into our lab. Without her, there's no Fumarate. And the microbiology lab, they actually did the initial evaluation. Jenny Stepp, also in the microbiology, she was the project manager during that time. We had meeting, and she's organized everything. And she's also the person to put every piece of data into the system daily during the flu season. And here I listed all the doctors from ED, from infectious disease, from lab medicine. They all helped tremendously for this project. Thank you. Yes?
So Min, very nice talk. Thank you for coming.
Thank you.
I actually have 2 questions.
Mm-hmm.
What's the Fumarate cost?
What's the Fumarate cost? The machine cost $50,000.
What's the reagent plates cost?
The reagent, one pouch is cost $119, something like that. A little over $100. The cost is high. But if you compare, there's a publication about compare the price of this and with the routine PCR method. It's not too much difference because it costs the labor cost and everything together. It's not that big difference.
And my other question has to do with your absolute neutrophil count. So your data you showed was percentages versus manual versus automated percentages. But how about, do you report percentages or are you reporting absolute counts?
Okay, the question is, do we report a percentage of ANC and the percentage of absolute count? We report both. We always have a neutrophil count percentage and also the neutrophil count absolute. So we basically have a poly and also have a band. I know you don't do it, but we can't get rid of the band. I mean, our surgeon use these numbers. So every patient younger than 3 months, we do a manual differential automatically. So we tried to get rid of band, we could not. So that's why we have absolute neutrophil count. It's the combination of the neutrophil, poly, and the band count. So we have both. So actually, this has happened when we have this, since it's automatic, right? We don't put any band count. There's no manual count, so there's no band count. Then they don't calculate the absolute neutrophil count. So all we give them is a poly. Then that created a little problem. But later on, we solve it. Yes, yes, Mark.
Very nice talk.
Thank you.
I have a question. Were you able to, on the downstream side, able to document a change in the time that patients spend in the emergency department, either from arrival to discharge or arrival to admission to the floor based on your response? That's one question. The other question, have you monitored the ratio of complaints to congratulatory phone calls from the emergency department as you've done this?
Okay, so the first question is whether we have a documentation on the back side. There's any, record of the patient from getting and out of the emergency department. And yes, they do have it, but I haven't really incorporated this into the, into our comparison, into our workflow. So yes, we can look at that. Well, we thought about this at the beginning of the second season. I talked to the ED doctors, and we were thinking about doing that, but just left out there, didn't continue. Yeah, that's something very interesting. And the other question is, I'm sorry.
It was more of a philosophical one. Are the number of complaints versus congratulatory phone calls different?
Well, in general, it's a lot of satisfaction. But during the when they get used to this, we get this 1 hour, 1 hour, 1 hour. But the flu season hit, then they complain. They really complain. So one time the ED doctor, Dr. Woodward, and he sent an email to me saying, what happened last night? So we seem to have 8 hours not getting a result. So I explained that to him. Then he said, oh, that's okay. Because he said he talked to his son and was in college somewhere else. And he said, no, he has the symptoms. And he told him to go to the hospital to get a PCR test. Then he came back to tell him it takes 2 weeks to get that. So he said, okay, that's fine. So there's a 1 or 2 days they really hit hard. We can only do that much. So when you have this all piled up, there's nothing we can do. So if you have 10 specimens here, we can't get out until at least 3 or 4 hours later. And also we prioritize. Sometimes when the ED patient comes, we do it first. If we have something lined up, then we probably get the hem-onc patient put at the very back. Then the complaint came. But only a few days during the flu season, the high peak time. Yes?
Thanks, Vin.
Thank you.
Questions about your display, the turnaround time quality metrics. The second report that you showed us in the spreadsheet, is that implemented in the lab system, or is that an application that the lab or the hospital wrote?
Hospital. You mean the question is the metrics we use, what kind of system we use. You mean the last one, right? Yeah, it's called a Tableau. I don't know exactly what it is, but it's how whole hospital use it.
Okay.
Yeah.
An additional question is, are there any other quality metrics that you look at on a regular basis that are, besides turnaround time metrics? I'm just curious to know the range of quality metrics that you're very consistently consulting.
Turnaround time and the corrective report. Yeah, that's something else we also look at. And what else? Mike, do you know?
Overtime.
Oh, overtime, yes. Overtime, yeah.
And then point improvements.
Point of improvement. Yeah, that's what we report almost daily for the huddle.
Thanks.
And then
Anything
there
else?
is a board, I think it's similar to what you have, no, where, you know, we have green, yellow, red in the core lab to see if something's getting past the time so that there's a visual cue, kind of.
Pending.
Yeah, so it went on a large screen. And then she didn't talk about the part of the core lab that's the processing, but there's detailed error metrics collected daily and reported on. You know, anything from misaliquot to delay in sharing tube or something like that.
Any questions? Well, yes.
I was just kind of curious. Obviously, there's a lot of potential places you can improve. Why did you, or what was the strategy behind choosing these specific tests to bring online?
Well, this is actually from Shun, Dr. Ching. And this is a new technology. She was so excited to have this technology. Yeah. Oh, repeat the question. What's the reason we put this, the Fumarate technology into our test, why we choose this? So this is just a new technology. So our microbiology director thinks this is significant.
It was driven by the pediatrician in chief of the hospital who said, you will put this in before the 2012 season. Because it's the biggest driver of of admissions in the hospital. And so he said, I don't care how you get this on, but this is going online this year because it's the biggest, in pediatric hospitals, it's the biggest issue is respiratory viruses by far.
Yeah.
And it drives,
Yeah.
half of our year is sort of dedicated to it.
Yeah.
So, and then Schwen found the technology, or she had been keeping up with it. But the driver was
the hospital, yeah.
and she,
Yeah, Dr. Mark Deborcaro really is the big force behind it. Yeah, he gave a big push. Yes. Okay, thank you. Thanks for coming.